First of all, I have to say that last speaker is a tough act to follow. What you've heard from the speakers so far has been wonderful in terms of the quality of what you're hearing. You're hearing people who are the tops in the field presenting the latest information that's not even, it's all new. A lot of this is new to me. Jenny's data that she showed you at the end there is precious data, and it's been wonderful. And I put myself a tier or two below that. But we have sort of a mini version in Missouri of what's being done here at Stanford. I don't have the wonderful support you have, and I don't have the brain you have, but we have collected about 50 patients now, and we're studying them in much the same fashion. And what you just heard described here at Stanford, we can replicate very, very closely with what we're seeing there in Missouri. And before I get to my talk, I also want to thank the organizers of this meeting. Diana, you've done a magnificent job. You've supported this. The team that's helping you, and then everyone here is just great. And I'll certainly echo what Jenny just said about the learning from our patients. That's really where we're at, and it's been an exciting endeavor. So my job is to just sort of say, where do we go from here? And this is a very immense topic with many, many facets. I can't possibly, the talk, I think, as I was thinking about this, we could come up with probably 50 questions, and I'm not going to try to address them all in the brief time we have. But I'll do some, and some of this is replication of what's had before, so I'll be able to skip ahead, I certainly hope. So we've already heard we're talking about basal ganglia disorders. There's a bunch of them. Here's 5 of the commoner ones, including Sydenham's, OCD. We've already heard about this, that there are many, many other autoimmune central nervous system disorders, of which here are some of the common ones: multiple sclerosis, paraneoplastic syndromes. You've already heard some of these names in previous speakers, NMDAR encephalitis, things that this is not, but have their own diagnostic techniques and their own specific tests that can be differentiated clinically and in terms of the lab. So first question, we can quickly skip through because PANS is an autoimmune disorder, and Dr. Sweeto already outlined all of the laboratory and clinical background for that. And furthermore, once you've decided that this is what it is, and I believe personally the vast majority of our cases are going to turn out to be autoimmune, and that the non-autoimmune subgroups is going to turn out to be minor. We don't know this for sure yet. But as you've already heard, this opens up the possibility for a variety of immune modulating treatments, which you've heard about already in great detail. And this is just, as Jenny just pointed out, there are tons more that we've learned from the rheumatologists that have the potential to also be applied here. And this is open season for us as in the field of PANS and PANDAS. So we're really looking forward to our planning meeting next month at looking at what kinds of treatments we can do, what order should we do them in, what combinations should we use, and where do we go next with that. And there's going to be quite a discussion about that. And hopefully we'll come to some sort of a plan as to, until the data comes, where do we start? And then how do we use these plans that we put together to generate the data we need to design more classical controlled studies to really give us the final answers. But the train is on the tracks, and it's a matter of time. Research occurs slowly, and if you're the parent of a child with PANS or PANDAS, it's painfully slowly. But it is moving forward, and I think as it picks up steam and we get more support from various sources, I think our collaborative group has an opportunity to help make this happen, and you all obviously have already begun to provide important support. Even I've gotten a small amount of money to help move our studies forward a little bit, which I appreciate enormously. And does prednisone work? This is all trial and error and anecdotal, but it surely seems to work at least for some kids, but it only works while you give it, and kids tend to relapse when they're off it, but it has a role, and we'll try to figure out where it fits best in the sequence of treatment courses. Does IVIG work? Has been a very controversial issue. Sue Sweeto has done the studies, and it's looking like it does, but exactly how to use it, what doses to use, how long to use it, is going to require more studies, as she's already pointed out. It may not work for everybody and may differentiate one group from another. If a child is prednisone responsive, that may mean one thing. If a child is not prednisone responsive, that may mean maybe a very important differentiating factor. And another question is whether a single dose may not be enough, and we may be developing regimens that require a whole series of doses for months at a time before we really find out that it works. And all of this just needs to be studied, It's hard, and it's been pointed out 5 times now, expensive to do this sort of study, but that's where it needs to go. And I think I'm very optimistic that we're going to begin to get answers. Now, here's where you all come in, and as Jenny pointed out, we learn from our patients, and it's the same way and I know how Jenny works up a patient, and we try to emulate that by getting the nth detail about what's going on, because you never know which detail is going to suddenly reveal something you didn't know before. I sometimes like to think of the way the various people, those of us who study patients like this are, it's the blind man and the elephant. We're all looking at this elephant from different angles, and she's looking at it from the rheumatology angle, and Sue's looking at it from the psychiatry angle, and I'm looking at it from an infectious disease angle, and all of these things, as you've already heard, play into the whole process. So the way we've done it in our clinic is actually develop a scoring system where the parent makes their own scoring system by listing the important symptoms for their own child, and then every day they give it a score from 0 to 5 at the end of the day. And people have thought, isn't that going to be very burdensome? And I said, you must not know these mothers and these parents, because this is just what they want to do, is to be able to help by providing these details. And when we do it this way, sometimes you pick out fine details that aren't obvious, or that might have been misinterpreted otherwise. And so I'm just going to show you 3 quick cases that illustrate this in some ways. Here's a child. This has aggression-dominated PANS, did not have a strep story either by history or by laboratory testing, and was one of our few patients who had all 5 of her molecular Cunningham panel antibodies be negative. So she sort of may be in a unique group already. We plan to do some further brain autoantibody testing with her, but this covers quite a long period from August of 2013 to April, in fact, just a few days ago, but it tells us a few things. One you can see here is where she received clindamycin, an antibiotic that has some very good streptococcal activity and a bunch of other biological antibiotic activities as well. And wow, it looks at first glance like this has really made a big difference for her. But if you look closely, you see this particular spike is already coming down when clindamycin was started. And as it was continued, she spiked right back up again. So what at first glance seems to be a response may actually be totally incidental. And I'm showing these cases not because they prove anything, except to show you how, by looking at fine detail day to day, can give us a little clearer picture of what's happening. And then here's a trial of prednisone in goodly doses, and you can see from her total scores during this time period. This was about 6 weeks. The scores dropped dramatically. And then in the next section is while we were tapering, everything came roaring back, and we were making plans to start IV gamma globulin. Things got so bad we gave her a little burst of steroid right beforehand, and again, you could see working. So you begin to see things happening over and over again, or from patient to patient, and then gradually with time we accumulate an impression about things. And prednisone is nothing new, really. I mean, anyone who's worked with these patients and tried it has had these experiences. So this gives us some confidence, without ever doing a formal controlled double-blind trial, that prednisone has a role. And then again, so she did receive her IV gamma globulin, and it took, and there was no change for a couple of weeks. And now she's gotten better, and she's back in school and functioning. So that's almost a 2-week period of jagged lines before you see in the last few days come way down to baseline. So we're watching with bated breath to see, is this real? Is it going to hold up? And whether it's due to the IV gamma globulin or not, scientifically, we can't say. We want so badly to believe it. The preliminary data that Sue's generated for us tell us we may be on the right track, and that gives us more impetus to use these things, to look at these things more aggressively. If they're not working once, maybe we need to give it over several months before we give up on it. It's such a relatively non-toxic treatment. and certainly has got a long history in treating other brain autoantibody diseases that it's one to follow. So this is where we're at in the process of thinking. And I think Jenny presented it the best, saying we're not quite to the point of doing controlled trials on some of these things yet, but the time is coming, and as we accumulate these individual patient experiences, we learn from our patients. Here's another patient that illustrates a couple of other points. This is a boy that we caught right at the very beginning, and I didn't know yet about the importance of doing MRI in the first week, or I would certainly have done one. He did not get one. But this is a boy who was a quiet, had some personality disorders. Well, I wouldn't even call them disorders. A personality of being very quiet and not very social. His father was the same way. So there was a little something going on, and then suddenly one day he had to stand exactly in the middle of the room where the lines intersect from the middle of the wall on one side to the one on the other, because if he didn't stand in that one spot, you know the story. So we heard about him pretty quickly, and the mom actually retrospectively put in the scores before this, so he really was at a 0 beforehand. And she had already scheduled him to have an intranasal flu vaccine, and on the first or second day of his illness, she went and got the flu immunization for him, and things got even worse. And this is a very touchy issue for an infectious disease person who recognizes and a public health-oriented person who recognizes the importance of vaccines for children's health entirely. And it brings up the whole issue of what do we say about the use of vaccines in children with PANS or PANDAS, and we have to be extremely careful, because if ever the idea gets into the public knowledge and into the minds of what I call the anti-vaccineers, who are very vocal, that vaccines can cause PANS or PANDAS, it could be very damaging for public health of children and adults in a very long-lasting way. So we have to be sure of what we're talking about. So if someone is going to claim that there's been a reaction to a vaccine, we need to have not necessarily even day by day, but even hour by hour stories carefully done prospectively before we start making any pronouncements about the role of vaccine, negative roles of vaccine in this disorder. So he fairly soon got treated with prednisone, did not have as dramatic of a response as the other person, but you can certainly see it looks like a trend that didn't hold up as it began right away to relapse as we started tapering. And then he got his IVIG, and again, you see the same kind of story. So with one more to add to our individual experiences about the role of IVIG, and he may wind up getting more than one treatment, we'll see. And here's a third patient, actually the sister of the first patient, whose numbers are much milder by the scales. And you can see again the sawtooth patterns. And this one I've put in the information about the symptoms. So we very carefully now separate out whether it's nasal infection, a stuffy runny nose, whether it's a sore throat, whether it's a cough, because all of those are anatomically different. Their immunological responses may be different at different sites. And so it'll be very nice to say, at this point, we say an intercurrent infection can trigger the process. As Dr. Frankovich pointed out, it may be very nonspecific, or it could be that some of these infections actually are very specific, and it's related to the site of infection or the microbe that's causing the infection. And as an infection person, that's one of my roles in our group, is to sort of focus on that piece of it. So we begin to generate this kind of data, these kinds of data, and hopefully we'll be able to say something about that as we collect more and more patients. This girl had the response, a very negative response, and got much worse right away after her IV gamma globulin. Do we know why? No. But maybe this sore throat and runny nose was related to this flare. This one may be related to that one, and maybe this little flare out here was related. We don't know, but it tells us what's the next question. We need to look at this more closely over time. Now, this whole question and controversy surrounding Group A strep, Dr. Sweeto presented in a very clear and altogether refined fashion, but it is still a question, is how does the strep A work? Why should it cause these diseases? What is the relationship between strep and the PANS and PANDAS symptoms? And so we've got some knowledge about that. Certainly, no one's going to argue now that group A, or none of us who really are involved with this are going to argue that group A strep isn't important, especially with the data that we just saw. And so and that's the definition of PANDAS. We have to have a clear association of A strep infection with either the onset or flares, and then also to support the strep roles. Many, but not all, the patients have high antibody titers. That's what ASO and ADB are, streptococcal antibody titers in their blood to say they've responded. And we've already talked about how those tests are not perfect. That's one area where we're looking for collaborators who can do much better strep antibodies than those two old-fashioned antibodies that are not always positive. And there's some great forward movement on the periphery that we hope to draw into our studies as we go forward. Another interesting thing about strep is that it persists. It can stay for months and months. Particularly stays in the tonsils. Remember, she talked about how vigorous you have to be to get it to come out of the tonsils. And at surgery, we sometimes find that that these organisms can colonize deep within the tonsillar tissue, maybe even beyond the reach of a culture. So it's possible that you can carry strep without even having a positive. A negative throat culture can be related to misrepresent whether the strep is really present or not. And one of the characteristics of ASO and ADB antibodies is that sometimes they rise and they stay up for months. And that's not usual for infectious diseases. And one explanation for that is that even though the throat cultures are negative, it's possible that that the organism is still there. And if that's true, there are more aggressive ways to treat. We don't think of strep as colonizing the nose, but we don't really know that in these cases. Perhaps there's some special relationship between strep and nasal colonization as well, and that's worth studying. So, and there are ways, as I say, to more aggressively treat the strep if we think it's still there, with combinations of antibiotics, for example, that we wouldn't normally be using. So strep clearly has a role, and is it two different conditions, one that's strep-related and one that's not? That's a very strong possibility. I think it'd be fair, Sue, to say that when you made that distinction, you did it for research purposes as much as anything else. And she already knew from that very first paper that there were other things that could cause it, including chickenpox virus, which we don't see anymore because of vaccine, and influenza is certainly on our list of causes. I think I've seen and others have seen cases that were clearly related to influenza. That's a disease that we have good tests for. They're done at the bedside, and so we recognize it when it's strep. Other of these infections, like mycoplasma, is much harder to recognize. So I think maybe we need to lobby for a rapid or for at least a less expensive PCR test for mycoplasma too, because it's so important. Mycoplasma is an organism that only occasionally has been related to PANS and PANDAS, but you won't know unless you do these tests. So again, this is a whole nother area that needs to be worked on, and I think fairly urgently, because mycoplasma is extremely common. It persists for long periods of time and could be an aggravating infection that we have a potential to treat. And with some of our antibiotics like azithromycin do, and others like the penicillins, amoxicillin, and augmentin, and the others don't touch that condition. So that will also be another important area to look at. Another question is, supposing you have a patient like the last one I showed, that none of the tests showed any evidence of strep infection. The history didn't show any sore throats even at the onset. It was as clear from strep as you could get. Clearly not a PANDAS patient at that point by our definition. Is that patient still susceptible to trouble if they catch a strep infection? Not so clear. May very well be. We certainly have kids who started out as being PANS and then did get a strep infection with a flare. So maybe we should, how we protect or try to deal with children that don't have PANDAS yet, don't have the strep piece in their history, should or shouldn't we be maybe prophylaxing those children, or at least aggressively following any of the slightest sore throat and getting on top of that right away, even though they don't have PANDAS? Another kind of question that we can ask going forward from the infectious disease point of view. We've also heard about attack sites in the brain. And then, so there are two pieces of that. One is the biological picture of the anatomic targets in the brain, and you've already seen this picture too. And it's the purplish area is the place where we think most of the action is. But we know that could be very well smaller pieces of action in many other locations in the brain, mostly concentrated in the so-called striatum, made up of the putamen and the caudate nucleus. And I learned from Sue yesterday that if it's putamen, it's more likely to be tics, and if it's caudate, it's more likely to be OCD. Did I learn it right? See, we're learning back and forth just being here at the meeting together, which I really, really appreciate. And then even more important, or equally important at least, is to try to discern what exact molecules, we call it epitopes in immunology, what exact molecules or parts of molecules are being attacked. If we know what the attack site is, it will tell us more about how this disease works. It will tell us more about what things that could trigger the disease, and it may even potentially lead to treatments, which I'll tell you about. So, and this is an area that's just in its infancy, but it's moving along, and largely due to the work of Dr. Cunningham. Just amazing work. I can say that not only is she a good scientist, the thing that separates a good scientist from a great scientist is that a great scientist knows what questions to ask, can figure out the ones that will most likely to lead to something good, and I certainly would put Dr. Cunningham in that category. So, and through her work, we've learned that one molecule or one part of a molecule stands out, so there actually is a potentially important target, and it's called GLICNAC, N-acetyl-D-glucosamine. It's a sugar. It's not too different from glucose. And it may turn out to be, from her data, it may turn out to be the key to the disease, or at least an important key to the disease, and a target as the target of the autoimmune attack, and she's gone a long ways towards showing this. So just a little microbiology. Over on the right there, you see a cartoon of a streptococcal organism, the inner circle, and it's coated by various layers, one of which is called the cell wall. That's hatched in the picture, and that cell wall does contain the sugar as part of its structure. And we certainly know that we certainly know it's immunogenic. Strep can cause antibodies to this GLICNAC to appear. In fact, that's how group A strep is defined, is by the antibodies to that cell wall. That's the test you do, is that molecule there, and if it is by immunologic test, it's a group A strep. That's how it's defined. So all group A strep have that by definition. And then what we've learned from her and others is that this GLICNAC is also present on the brain targets. So here's the same picture drawn a different way over on the right of a bacteria, and the red in the picture represents that cell wall where the GLICNAC exists. And it happens that it's much more common in the so-called gram-positive bacteria than it is in the gram-negative. Those are two major classes. Most bacteria fall into one or the other. So we're thinking if we're going to look for bacteria other than group A strep, those gram-positives would be the most important. And you can see, here's the molecule in the upper left here, the GLICNAC molecule, if it's all by itself, but actually it exists within, it's part of a larger molecule that makes up the peptidoglycan layer of that outer membrane. So in other words, there it is, but it's a piece, just part of another major, larger structure that makes the wall of the bacteria. And somehow it induces antibody when it's given. So this is the second time this picture has been shown, and she deserves it. That's Madeline Cunningham. And so she has starting off with studying rheumatic fever and then Sydenham's. And at that point, when she was working on Sydenham's, Dr. Sweeto knew about her work and called her up and said, "We've got to do this for PANS and PANDAS." She got her, and so that's how that relationship was started. And so we've come quite a ways over the last few years from this work. And so now when you send a so-called molecular Cunningham panel, it's available commercially now, very expensive and sometimes hard to get done, but it's doable. She will do the antibody tests for the dark ones, anti-dopamine receptors 1, 2, anti-lysoganglioside, anti-tubulin, and 3 of the 4 of those are known to be on the outer surface of the neuron cells, the brain cells. Those are out on display where they're reachable by antibodies potentially. Tubulin is more intracellular. And then this CAM kinase 2 assay uses live growing, dividing neural cells. They're derived from a nervous system tumor, actually. And when you mix them with antibody or serum from your blood from the patient, the antibody acts like a hormone. Instead of attacking the cell, it attaches to it and acts like a stimulator and turns on the cell. The cell becomes active and it produces CAM kinase 2 and some other things. And it's of interest not only because it's a bioassay to reflect actual biologic activity, but the pathways that are involved are dopamine pathways. They're pathways that are definitely targets of our whole system. So we think all of these together are important. And as we do these on more and more patients, we find out some patients have none, a few patients have none. Some patients have antibodies to only one, some have two, some have antibodies to all five. What do those mean? How do they interact? And then Jenny's been doing antibodies to other things like the histones and so on. And how do those all tie together? Do they cluster together and give us different syndromes? Does some antibody associate it with some syndrome? All this is very important to know in terms of leading towards specific treatments. And those are answers that are now going to be possible with what we have today and as we accumulate these patients' series now. And she's added in the gray there is now a sixth test that they've added and also seems to add to the panel's ability to diagnose. And you've already heard how this relates to Sydenham's chorea has these antibodies. PANS and PANDAS tend to have the same antibodies, sometimes to a lesser degree, sometimes to a greater degree, as has already been pointed out. So we've already talked about the glicnac. We've talked about the fact that it's part of the cell membrane of the strep bacteria, and she's also determined that it's part of the structure of these very antibodies, these very structures that are being attacked. So the pieces are all coming into place of this puzzle. So if you look over on the right, there's what the and the glicnac looks like by itself, and there it is, the structure buried within lysoganglioside. Here it is in one of the dopamine receptors. This is the wall of the cell here, of the nervous system, brain cell here, and the dopamine receptor is stuck into the middle of it, and here sticking out in the breeze, right in this region, is where there's a glicnac molecule. So you can see now how this is so-called molecular mimicry, where the body reacts against a part of the strep and by mistake overdoes it and makes antibodies they're not supposed to make that react against self and then somehow generate this disease. So this is one of those strong pieces of evidence that make this an autoimmune disease. So now we've raised this question. Glicnac is present on a bunch of different bacteria besides group A strep. Might they be relevant? We do not know. Another set of important questions from the microbial viewpoint, the microbial blind man looking at the elephant. And the common ones beside group A strep are there's a group B, C, and G strep that all are fairly common infections in people. And commonest of all are these last two, pneumococcus and staph. And I think that my impression is that these staph infections have gotten to be roaringly common in the last 10 years, and they hardly ever get these histories from our patients with PANS and PANDAS. So this one somehow doesn't come onto the radar as much. But this one is the commonest cause of sinusitis. In fact, even non-sinus, just a runny nose with purulence in it, often contains these pneumococci. So now when we're talking about immunizing children to prevent infectious diseases, in terms of influenza, we might be adding pneumococcus to the list if we can put this piece into the puzzle too. It's not there yet, but it's a clear organism that should be looked at next. My time is running out. Just to say that pneumococcus is high on my list of other organisms to study, as is mycoplasma, and there may be more. Now, we've got this list of now 6 sets of antibodies that are useful, and in my mind, we've just scratched the surface. There may be 100. People who deal with lupus now have available panels of, 100 or 200 in these microarray, antigen array systems that are defining lupus even better. As Dr. Frankovich pointed out, we've learned so much about lupus over the years and what these antibodies, and there are many different autoantibodies in lupus, and it's going to even enlarge much, much more. And as we get different patterns from these microarrays, we'll wind up better able to define lupus, and there's no reason to believe there won't be 100 brain antigens that might be important that will help us subdivide these patients as well. I'll skip through blood-brain barrier. We already heard about that quite a lot. And I'll go right to the Holy Grail in my remaining 60 seconds. So the ultimate dream would be to say, we know that we can make vaccines to prevent infectious diseases. You're trying to prevent influenza, you give a vaccine, the host makes antibody to the vaccine, the antibody is good, it kicks out the influenza whenever it comes. We know in these diseases the host is making antibody to self-brain antigens, and it's as it shouldn't, and we wind up with an illness. Is there a way we could make a reverse vaccine that will turn off an immune response? And I wouldn't be telling you this if there weren't data emerging on the horizon that in fact is a possibility. The studies were done by, it's interesting. The studies were done by Dr. Habib Zagwani, who also happens to be a friend at the University of Missouri. He's a brilliant immunologist, not a clinician. And he's worked out a way to make an anti-vaccine or a reverse vaccine. I call it a tolerizing vaccine. Tolerance means you're able to tolerate yourself, and you're being intolerant if you're attacking your own brain. And what he does in mice with juvenile diabetes, an autoimmune disease against the pancreas, is he takes a cell that produces tons of just a single antibody molecule like this, and with genetic engineering, he can take the important self-antigen and by sticking it into the gene in the right place, he can get the antigen to appear as an integral part of this molecule. And when he uses this with repeated doses, he can make the autoimmune response go away. It activates, it is presented in such a way that these bad T cells find it, get attached to this, the cells that are presenting it, and they just vanish. And the diabetes is stopped. And this is a model of juvenile diabetes, and they're working next on the next phase of humanizing this process. So if we can identify these specific targets in PANS and PANDAS, and GLICNAC obviously is right there in the middle of it, it potentially could become a candidate to be treated in this way. So this isn't tomorrow, this isn't next year, this is probably 10 years down the road before this sort of thing happens. But that too is just an exciting possibility for the very long range future. Thank you very much. I only ran over by 2 minutes.